thanks to our little select group that have joined. Hopefully we'll have a really good discussion afterwards about this. I think it's a really important thing that we need to be raising awareness of. I think cervical screening is important anyway, but we all know that cervical screening within severe mental illness is a particularly complex, difficult thing to get people to do because of lots of different reasons. And today I'm really, really pleased that we're inviting both Frederique and Beth to give us a talk about this. So Frederique holds a PhD in health psychology, and her research focuses on improving healthcare access and outcomes for people living with severe mental illness. She's previously worked in research to improve diabetes care within the population, and later developed an intervention to increase cervical screening attendance among women living with mental illness. And this intervention has been incorporated into UK government guidance and is currently being evaluated in an NIHR-funded feasibility trial. Frederique also sits on the National Advisory Committee at Equally Well UK, and she's been on that since January 26. And she continues to serve as a consultant to the World Health Organization, contributing to work within the healthy aging and mental health teams. And in parallel, she conducts health services research within the NHS and has recently focused on health inequalities in the treatment of aortic stenosis and the management of comorbidities. She's also a member of the Research Ethics Committee for an international NGO. And Frederique and I had a good chat about her work. Gosh, that must have been a couple of months ago now. Was it 6 weeks, something like that? Yeah. Really, really interesting. So if you ever want someone to talk to someone who's got an interesting, varied work trajectory, then Frederique is definitely your person. And so we move on to Beth, who hails from my neck of the woods up in the northeast. And Beth is a research associate at the NIHR Policy Research Unit for Behavioural and Social Sciences, based at Newcastle University. And as part of the policy unit, Beth works with policymakers to conduct and deliver timely and policy relevant research. Beth also holds at NIHR 3 schools postdoctoral fellowship, and her research focuses on disease prevention. Well, super congrats on the postdoc. They're really hard to come by. So I hope you gave yourself a nice celebratory pat on the back for that.
Thank you.
So today the title of the talk is Improving Cervical Screening Uptake in Women with Severe Mental Illness, Designing, Delivering and Evaluating a Co-Designed Intervention. And I'm hoping that we can all learn something from this today. And when the presentation's finished, I'm really looking forward to the conversations that we're all going to have afterwards. So I probably should have started with, I was so focused on the dogs barking, I never introduced myself. So hello to everyone who's joining us for the first time. I'm Jo Howe, and I set up the Mental Health Innovation and Improvement Network. It was about a year ago, following work that I've been doing at Aston University around improving the physical health of people with severe mental illness. I'm now working as an independent researcher, which is an interesting space to be in, but actually still very much working in this field. And I'm currently developing a booklet, which will be going live soon, for people who are first prescribed antipsychotic medication to help them cope with the side effects of the medication. So there'll be more on that because we're going to do a session on it later this year. So without further ado, I'd like to now pass over to Frederique and Beth for their presentation. Looking forward to it, guys.
Thank you. So thank you so much for the introduction. You can see my screen, I presume, my slides. Just checking.
Yeah, perfectly.
Yeah, brilliant. Yeah. Okay. So this, what I'm going to present today is part of my PhD, which I did a few years ago. I finished in 2020, and it was developed the outline. So the presentation, we've already gone through this slide. And this was my PhD. So just to acknowledge my supervisors, so Professor Barley, who's a health psychologist, Professor Henderson, who is a psychiatrist at King's, Professor Lafarge, who's a psychologist, and we also worked with Joe Cervical Cancer Trust. So I reached out to them during my PhD. Sadly, they no longer exist due to lack of funding, but they were very helpful in setting up the booklet and disseminating it. And I was funded through a scholarship. So really, I came in having done a lot of work on diabetes care for people living with severe mental illness, and I was interested in developing an intervention for this group to improve access to care particularly in primary care. And I was quite struck by when I saw the cancer that there's the same incidence as the general population, but those living with severe mental illness are more likely to die from cancer. And research has shown cancer mortality tends to be 30% higher in people with severe mental illness than in the general population. And there are lots of reasons, but one of the two of the key ones. So one is that people who are living with severe mental illness are more likely to present later, sort of more advanced stages. And this delayed cancer diagnosis could be due to postponing or delaying help seeking due to some of their mental health symptoms. And another factor which contributes to their poorer survival rates after cancer diagnosis is unequal access to cancer screening. And this is why my supervisor and myself decided to develop an intervention or explore what could be done to make sure that everyone is able to make the decision whether or not to attend cancer screening. And we went for cervical screening because it has the biggest population that it could support. So there are lots of different, so the first thing I explored during my PhD were looking at some of the barriers to cancer screening uptake. So there were some which obviously are very difficult to address in a PhD. So they're more environmental, systemic factors. So for example, if a person is not registered with a GP or unfortunately has been barred from a GP practice, or we found out that in some forensic services, people aren't offered breast screening, for example, or cervical screening or bowel screening kits. So those are definite barriers. Then there's the more sort of individual belief systems. So people worry that the smear test could trigger flashbacks. And I worked with a lot of women when I was developing the PhD who've experienced trauma. So that was a clear barrier. And then there was the symptoms of the illness. So they didn't necessarily have a problem with going for screening, but they felt, for example, I don't like going to my GP practice because it's very noisy, it's very crowded. So what could be done to kind of support that barrier? So those are the kind of things that we explored. My first paper, which I published during the PhD, was we wanted to look at interventions that increase access to or uptake of any type of physical health screening in people living with severe mental illness. It was a realist review, which I know Joe's an expert on, but we didn't know each other at the time. And really the idea was, it was quite a large one, so 22 included studies to looked at interventions that have been evaluated and developed to increase this and to see what kind of intervention could we think of developing for my PhD. And we went with a very simple informed choice tool. Sort of the aim was to give any woman the maximum information so that they can make the choice whether or not they want to go for screening. And as I was developing the PhD, I realized that actually there are many women in the general population who might struggle to go for screening. But because this was still an academic exercise, I had to sort of stick with the more severe mental illness, but actually we realized that many women have anxiety about going. So actually the leaflet is useful to any women who struggle to go. And then once we decided we were going to do an informed choice tool, I thought, well, let's look at whether anyone else has developed an informed choice tool specifically for people living with severe mental illness. And so I did another systematic review, and there were not many. There was one in Germany, one in the US, and one in the UK, which was around decision making around whether or not, and this was developed by my supervisor, Claire Henderson, to whether or not to disclose that you have a mental illness before when you're going for your job interview. So there were different informed choice tools for different purposes. And we looked at, have they been evaluated? Were they effective? And that was really useful when I was developing. So sort of very simple tools came up, sort of use a dyslexia friendly guide, use particular fonts, not too much text, what kind of images. So it was really useful. And I sort of developed like a blueprint almost of an informed choice tool template for people living with severe mental illness. This is the page, the first page of the booklet, the Informed Choice tool. And we worked with service user groups, of course, during the PhD. And this was an idea of one of the service users I worked with. And she said, sometimes it just starts by someone's having a chat with their friends, they're having a tea, and they're saying, oh, should I go for and this was actually her, should I go for a smear test? Yes, this leaflet can help. It's got lots of tips. So sort of trying to make it not clinical at all and sort of starting with a conversation amongst friends or family on whether or not to go for screening. And the leaflet has lots of information, which I'll go into, but one of the page that has been the most useful or successful, if you like, was the one where women that I interviewed were asked, well, what do you struggle with and what might help? And what a lot of them, without articulating it as such, was that I have this problem or there's something I struggle with, but I don't want to talk about it. I don't want anyone to sort of probe me or ask me questions in primary care or in any setting, but I would love the person to know, so that if I react in a weird way, then they know. And so these are some of the things that were listed that women wanted the nurse to know, but didn't necessarily want to disclose. So that's you can see the list there. So I have a little video which I can share with you. Sorry, I'm just going to now stop sharing and sorry, I have to share again. Apologies. Here we are. Okay. So this is a video that we got funding for, and it's called SMI, Science Animated, and it sort of explains the role of the leaflet.
Some women find it difficult to go for cervical screening, also known as a smear test. This could be for a number of reasons. This leaflet gives practical guidance on how to plan for your cervical screening, like booking the first appointment of the day if sitting in the waiting room makes you anxious, and wearing a skirt or dress so you can keep these on during the test. There are suggestions for while you're waiting for your appointment too, such as taking something to read in the waiting room, or asking a friend, relative, or mental health worker to come along for support. The leaflet has tick boxes to help you share information with the nurse without having to talk about it if you don't want to. So, if there are things you find hard to say, you can still communicate them to the nurse doing your cervical screening. After your appointment, make plans to do something nice and relaxing. The leaflet also has information about what cervical screening is, where you can get support and what symptoms to be aware of in between visits. You can access the leaflet online. This NHS leaflet was developed in collaboration with women who use mental health services, professionals, and frontline staff.
Okay. So, apologies. Right, so that was that. And actually, one of the learnings from my PhD was that when I started doing the PhD and I started thinking about what support we could offer, what is available already that some women might not know of, and I was very much focusing on after. So you have your smear test and it could trigger you, could make you upset, and then what kind of support is available after. And actually, during the PhD, from talking to all the women, they said, well, actually, we need to help before. We need support before going for the test, because actually that's when we get anxious and that's why we might not attend. So that was very interesting learning for me. So the first stage when we developed the leaflet, I won't go into all the details, but very briefly, so we had service user groups, but we also worked in mental health trust and community mental health teams, and we looked at what we call the acceptability of the leaflet. So we tested it. We also had a sort of a clinical guidelines group, but we tested it with some service users, health professionals in 2 trusts with an interview. And I also had a key informants group from Public Health England, etc. And there were different revisions. The 2 that I will mention briefly. So one was on the terminology. So there was a lot of discussion around, I think the charity were more in favor of signposting it as a leaflet for women with severe mental illness, but actually people who worked in mental health services, including the women and other charities, felt that this might be sort of unwillingly being stigmatizing. It signposts it, it narrows it down as well in terms of who they think it might be appropriate for. Some women also don't accept the diagnosis. So there were lots of discussions around how to signpost the leaflet. And the second one was some patients and health professionals were very much focusing on cancer prevention, and the others were more about, let's not talk too much about cancer, let's think more in terms of health promotion. So if you look, there are two quotes that I pretty much sort of opposite. So one was telling me, there's too much mention of the word cancer in your leaflet. It might worry someone who's paranoia or health anxiety, and they might think, I'd rather not know. And another nurse told me, don't be afraid to be explicit about the risks involved if they don't go. Don't be scared to use the word cancer. So I had to sort of balance that out in the leaflet. There were other quotes, other comments. So some women liked the tick box page. They said the leaflet gives legitimacy to her worries about hearing voices. There were also a lot who liked it because they had scarring and they felt judged when they went to primary care, and so they felt that having that tick box was useful. A mental health nurse said, asking open-ended questions can sometimes be overwhelming, so having the tick box is helpful. And then other things in terms of there was a gap in terms of what was available. So it's like sexual dysfunction for men on antipsychotics. Don't always think to check, so the leaflet is useful. And one service user said it would be helpful to avoid using purely medical language for mental distress. So we revised the leaflet based on the feedback that we received. And then the second phase was more in terms of what we call the usability. So in terms of the format. So it was a slightly smaller group. So we used the think aloud methods. So they had to go through the draft leaflet and then just speak out loud. What were their thoughts? So someone said, perhaps the leaflet is a little long, might be overwhelming for patients who are quite anxious, but actually, having said that, there are no sections I would remove, and you don't want to undersell the importance of the test. And one service, can we have an image of the cervix, which we included. So we then it went through those revisions, and then once we had sort of the final draft, we went back to the clinics and did not a trial at all, but just like a small pre-post evaluation. So we asked them, we used these validated scales with 25 women. And what we found was that for those women who already said that they would go for screening, obviously the leaflet didn't have an impact on that, but they did feel that the leaflet might improve their experience of going for screening. And actually, we know from research that if you have a bad experience, you're less likely to attend in future. So, another sort of positive spin-off was that it almost acted like a public health tool, sort of improving their knowledge of symptoms of potential cervical cancer. So those were two sort of positive. And for the women who categorically would not attend, there was not enough evidence in the at the time to include going for urine sampling instead of a smear test. But there is a group of women who said we won't go at any cost, whatever is suggested. But there are sort of other alternatives that could be explored in the future. And so I finished my PhD in 2020, January 21. So I was examined by Dr. David Osborne. And then we were very happy that it became guidance. So it was sort of, they broadened it a little bit in terms of for women who find it hard because of a mental health condition, previous traumatic experience, or sexual and/or domestic abuse. And during my PhD, I worked with a lot of charities. One amazing charity in East London working with survivors of FGM. I worked with a brilliant clinic for women who have survived domestic abuse or sexual violence and who struggled to go for a smear test. And so it was a specific clinic called My Body Back. So all of that sort of fed into how we developed the leaflet and the video. And we published the results. And now I will hand over to Beth, who has done a fantastic job of doing a trial for the leaflet. So I will stop sharing and talking, and yes, over to you.
Thank you. Can everyone see that? I'll just put this round.
Yes.
Thank you. Hello. Yeah, so I'm going to present kind of now taking it and trying to implement it, the resources that Frederique produced in some way, specifically using text message reminders. So I'll just start by explaining a bit about who I am, where I'm from. So I'm from the Policy Research Unit for Behavioural and Social Sciences. So we're based at Newcastle University, but we're spread across 5 different universities. And basically, we work with policymakers to co-produce research. So we have a liaison officer in the Department of Health and Social Care, and he links us with relevant policymakers. They'll either come to us with questions that they need research to look at, or we might come to them and we kind of work with them to address policy relevant questions. And we've had a couple of cervical screening projects in the unit. The first one I'll talk through briefly, but we had links to policymakers and people in NHS England in this area, and so we saw it as a relevant thing to look into from our point of view. And so we do have quite a big and diverse research team. So we're based in the Peru, but we also had researchers and of course worked with Frederique on this. And yeah, like I said, we kind of looked at the text message reminder as the opportunity here to deliver those resources, so namely the animation and the leaflet. So currently the screening programme in England is, well, it used to be for people aged 24 to 49, got invited every 3.5 years, and people aged 50 to 64 got invited every 5 years, but now everyone gets invited every 5 years. But basically, you receive an invitation letter. Then 2 weeks later, you receive a text message reminder. Now, not everyone seems to receive this. The screening programme seems to change weekly and it depends on the area. But this is generally what we could kind of cobble together, what generally happens. So you receive a text message reminder. Then if you don't attend after 18 weeks of being invited, you're then sent a follow-up reminder letter. And if you still don't attend, you're classed as a non-responder. So that just means you haven't attended cervical screening in the allotted time when you were due. So like I said, we wanted to use this text message reminder as an opportunity to deliver these resources to people with severe mental illness, the people who might need it the most. And we knew that text message reminders were effective at increasing cervical screening attendance in the general population. So this was a couple of randomised control trials that were conducted looking at text message reminders with different content of the text and whether they could increase cervical screening attendance. And it found that, yes, such a kind of low cost, low intensity intervention significantly improved cervical screening attendance. And that those trials also found that content mattered. So they tried out different content. So some of them were framed around social norms, you know, others like you attended screening, some were framed around loss. So, you know, around the risk of cervical cancer, some were framed around gain, you know, what could be gained from attending screening. But the thing that came out as the most effective were what they called GP endorsed text message reminders. So all that meant in reality was that the text message reminder, which is here on the bottom of the slide, included the name of that patient's GP surgery. And the kind of behavioural idea behind that is that generally people trust their doctor, their GP a lot. And by having their name in that text message reminder, it indicates that those reminders are endorsed by a really trusted source. So we'll call that the messenger effect. It's delivered by a trusted messenger. So that was really interesting. And subsequently, these text message reminders, so the ones containing the GP practice name, were implemented across London. And that was the other PRU project that we did. So we did a London-wide evaluation, real-world evaluation of these text message reminders. So we compared people who received one of these compared to people who didn't, either because their GP wasn't signed up or because they didn't want to receive text messages from their practice. And again, we found that it significantly improved attendance. So we have pretty strong evidence that these GP endorsed text message reminders specifically increase cervical screening attendance. And then what I kind of think about in terms of what we then did was in terms of Marmot's proportionate universalism. That's a tongue twister. But basically the idea that services should be universal, they should be delivered and accessible delivered to and accessible by everyone. But the scale and intensity of that service or intervention is depends on the need. And so that was kind of my thought, was that we know that these text message reminders work for everyone, for the general population, but how can we use these text message reminders to provide additional support to those that need it the most? And as Frederique explained, at the time at least, cervical screening attendance was lower in people with SMI. So that was the kind of the population of need that we identified. And so we looked at inserting links to the animation and the leaflet in these text message reminders. And we also framed a bit of content here around social norms, and that was through some involvement we did with people with SMI. So it says, worried about attending, other people have found these resources useful, and it just contained links to the animation and the leaflet, and that was the government leaflet because that was readily available. So we didn't just focus on people with SMI, they also had to be classed as non-responders. So that means that they were invited to attend when they were due and they didn't respond within the allotted time. So quite a specific population we focused on. And then we compared this text message compared to the standard one. So either the one that just has the GP surgery name in it or the one that has the links to additional resources. And yeah, I should highlight that this was just a pilot trial, so we can't kind of infer any effectiveness from these results, but it was about looking at A, is this a way that the resources can be delivered to those who need it the most? And B, could we evaluate it using this design of trial? So those were the two things that we were able to look at in this trial. So this looks a bit confusing, but I think it kind of talks through the flow of exactly what we did. So we got approval from the CAG, the Confidentiality Advisory Board, which basically just means that you have approval not to gain informed consent from every participant. So that meant that it was an opt-out model instead. So we informed participants right through that they were part of this study and they had the option to opt out at a number of different points. And so what that meant was we could recruit on the GP practice level. So we identified GP practices in London who were willing to participate, willing to search their records for eligible participants, and they would be the participants. So we created a pre-specified computer code, and basically they applied that into their systems, into EMIS, to search for eligible participants. So that was people with SMI who were classed as non-responders. And then the GP practice was able to remove patients at their discretion. So if they felt it was inappropriate for them to be included in any way, they could basically just remove them from the list of participants here. And then, so I think at that point we had 14 GP practices. They sent their lists to iPlato, and iPlato are the text message provider service at that time who was providing text messages across London. And they basically randomized that list of participants to either receive the control reminder or the one with the links to the additional resources. And then after that, so after the study period, which was 18 weeks, iPlato then sent the lists back to the GP practices, and the GP practices again applied this code that we'd written for them to EMIS to retrieve relevant participant data. So that was, did they attend their screening in the allotted time and other relevant demographic characteristics. They then sent that back to us, and that was our final data set. So we ended up randomizing 75 in each group, and we had just over 100 participants in the end, or when all of that process was done. And then to look at whether participants actually accessed these links, we did pick up data on whether the links had been clicked on, but we also wanted to find out, were people using them? Did they find it useful? So we also sent out a survey via text. So this was asking the participant, did they access the links? Did they use them? How did they find them? Did they find them useful? And I think another relevant thing to note here, because this trial went on for quite a long time, it went through different people leading it as different staff moved around. But basically in that time, the link is now provided in invitation letters as well. So that was a bit of a, we had to make sure that people weren't just accessing the links from the invitation letter, which everyone received, but that they were accessing it through the text. So those were the kind of questions we also had to tease apart in this survey, is where did they access the link from? But as you can see here, so we sent that to everyone who was randomized. We asked them to complete it, but we had a much lower response rate, basically, because that was something that was actually required of them. Everything else didn't require anything of the participant. And we only had 9 people in total completed the survey, which means we don't really know whether people were accessing the link, where they were accessing it from, or how useful they found it. So other findings of note was, I think this is just a big achievement and finding in itself, was that there was no opt-outs. So no participants actually chose to opt out, even though we gave them, you know, we put posters in the GP practice, we put it on the text that they could opt out at various times on the survey, but no one actually opted out. And I think that shows, you know, it was acceptable. And this is a really feasible way of doing this kind of low risk research. And quite surprisingly, we found there was a really high delivery rate of the text messages, higher than we expected. And like I said, this was a particularly disengaged patient group you could consider. So that delivery rate of the text messages, I think, was really high. So it does get the resources to the people we need it to. So that was a really positive finding. The main difficulty was in extracting the patient data. So once that the list of participants went back to the GP practices, that was the big stumbling block, because the code that we had them apply wasn't applicable to every GP practice system. And I think this comes up again and again in research that's based in GP practices, is there's different systems. It makes it really hard to work across them and to get the things you need from them. And it's a huge barrier to research and probably practice, I can imagine, as well. So that was the biggest barrier, and that's why we lost the biggest chunk of participants, was because GP practices were unable to retrieve that patient data. And also, like I said, we don't know if participants definitely accessed the links from the data on whether they clicked on the links. There was quite a big proportion of people that did click on the links, but we don't know what happened after that. And so when we're considering the next stage, which would be a fully powered randomized control trial, which means we'd actually know the effectiveness of these text messages and these resources, we need to first iron out, are people using them, are people using the links, and fix this use of GP records, see if we can get the participant data in a different way. And so some implications and questions, hopefully, that might spark a bit of discussion are these findings applicable to other types of cancer screening? I can see that they definitely could be, both the text message reminders and this way of delivering further support to those that need it. I think the big thing is this relies on delivery of the text message reminders. Like I said, it was actually higher than expected in this population. But could it be better delivered via the NHS app? I know there's a big push towards the NHS app. Could this be a better way of delivering the resources compared to text messages? I'm not sure. It would be really good to know, yeah, to be able to speak to some of these people who were participants and really get their idea on when the text message came through. Did they trust it? How did they feel about these resources? That would be the golden data, I guess. But because this was an opt-out model, they weren't particularly involved. They didn't choose to participate, and I think that kind of explains the low survey response rate as well. Another thing I've kind of considered is, should these enhanced text message reminders that we called them with these links that Frederique co-designed, could they just be sent to everyone? Because like Frederique mentioned, it's now open to anyone, that government guidance, to anyone who feels nervous or anxious about attending. So you could see that this could actually benefit a lot wider of a group of people. And so when we're thinking about the next trial, potentially we could just send the text to everyone, because there is an expense to having to identify the relevant people, so people with SMI who are non-responders, to then specifically send the text messages to them. And like I said, the biggest kind of thing I wish we could fix is the interoperability of IT systems across GP practices, because it's a barrier to research to bring in that. That was the biggest chunk of participants were lost there, which feels like a big loss. They'd already received the intervention, we just couldn't get their outcome data. So yeah, thank you very much. I think we've whisked through that pretty quick, but hopefully plenty time for discussion. I'll stop sharing. Thank you.
Hello. That was awesome. That was awesome. Thank you so much. So much to unpack. So I don't know if anyone's got any questions. Normally we would put information in the chat, but there's actually so few of us. I actually think we might be better to have like a discussion together as a small group. I think that might be more meaningful. But before we do that, can we just give like a round of applause? I like to do old-fashioned clapping. I know lots of people these days like to do digital hands, but anyway, thank you very much. Because if we were in a proper lecture theatre, we'd be doing that. Thank you very much. I really appreciate that. Perfect. There we go. We got some real, I don't know, that's some real noise there. You're doing well. So if I just think it just seems to make sense to move this. And there's so many things that I was sparking off my brain as you were talking. One around, the risk of cancer. And that was a shock for me as well, Frederique. The risk of cancer is no different to the general population. And I thought it would have been, given the risk factors associated with SMI. And that was a real surprise for me. But in improving the access to screening, the diagnostic overshadowing, the fear of health services, I think they're all things that we need to do to tackle that across the cancers, not just with cervical cancer. And I think that would be a good way forward. But then when we're thinking about like just the last bit, Beth, we were talking about like the app and the applicability of that. So one of the things that we're looking for the digital booklet, so we're designing is basically sort of like a PDF now, but we're thinking about the future, and it's like, what and how does that look like? Is it a separate app? Does it sit within the NHS app? To be fair, most people hate the NHS app. And then every time you go to a hospital, you get a separate app that you have to download, which drives people mad when you get, multiple referrals. So anyway, loads and loads to unpack if we had that inclination. But Suzanne, I can see that you've got your hand up. So do you want to kick us off with our questioning?
Hi, yeah, so it's not a question particularly, looks like a great resource. It was just sort of, I was thinking while you were talking about people with SMI, people with trauma, I think it would also be fantastic for autistic women, especially with the questions like, do you prefer a firm touch, soft touch, things like that. I think that would be very beneficial for people with sensory issues.
Yeah.
Yes.
And I think I read some literature that said something like, I think it's fairly underdiagnosed, but there's at least a 30% overlap between autistic spectrum disorders and severe mental illness. So it's likely if we can improve accessibility for one group, we can improve it for multiple groups anyway. So I think that's a good thing to say. Tracy, you've also got your hand up.
Hi, it's just a quick question. I'm a physical health nurse and I work within the mental health perinatal team. And I have already tried to look into supporting the ladies that access our service to access for their cervical smears and stuff done. And currently the trust that I work with has a nurse that works in, but she'll only covers one of the areas I currently cover. And I was just following the presentation, I think that the use of your leaflet, if it was accessible for us to hand out to those that are refusing to, or I've just got concerns about attending, if it could be used within the clinics that I do, the physical health clinics, to support them prior to going out, if it would be able to be used.
Of course, yes, it's freely available. It was on the Joe Cervical Cancer Trust, but luckily my supervisor had also put it on the University of Surrey website, so I can share the link with you. Absolutely, I can do it now in the chat.
Thank you.
So the video and the leaflet are free to download. We wanted to make sure it was accessible to anyone. Obviously, there's a printing cost, and I did make a print run after my PhD, but we ran out quite quickly because we also delivered it to sexual health clinics. Yeah, but absolutely, I'll send it now.
Thanks.
Frederique, I'm hoping, shall I ever get enough time? I think I need to clone myself, but I'm hoping to set up a website for the network. So depending on what permissions you had, once that gets set up, we could potentially put a link within the website as well, just to help signpost people. Because I'm hoping that we can create like some sort of centralized hub for things that do exist, so that if something is discussed on the channel, then, you know, through the network, through these videos, that people can go to the website and try and find it. I have no idea how that's going to work. And like I said, I need to clone myself first because I'm not the world's best. I'm a bit old dog, new tricks with like websites and things. And unfortunately, you know, I don't have a private income to support all of that. So that goes a little bit in the thing. I mean, one of the things that was, I suppose, interesting me, because I'm not a practicing clinician, as those of you who regularly attended will be aware. Currently, how is cervical screening managed within healthcare? Is this something that secondary care do try and get involved in, or is it very much left within the realms of primary care? I'm very interested from anyone. Just pitch in. Don't need to. Yeah, Sarah, put your hand up.
Hi. So currently, it's all primary care, but what we find is, as is the case nationally, a lot of people don't engage in NHS screening programs. So what we did a couple of years ago was we thought we're going to try and utilise that window of opportunity when people come in for an inpatient admission. If they're mentally well enough, we'll have a conversation with them about screening eligibility, maybe red flags, and then offer to support them to access screening. And I know that around the country, there are increasing numbers of mental health inpatient services, either providing that in-house or making those connections with outside agencies. Now, what we have found when we've spoken to gynecology, who are best placed to do this, is that actually you're probably better off trying to set up pathways to book people into local gynae clinics or coloscopy clinics, rather than trying to get back into primary care or try and upskill your staff to do it in-house, because they have the right chairs that are comfortable, rather than us trying to squeeze someone onto a thin couch, or worse still, doing it in someone's bedroom on their bed, because people need to have a safe space. And also they're really well trauma informed. So we've piloted it, and we're now currently, because we link up with 6 different local authorities and acute trusts, we're trying to set up pathways for routine screening, because they have targets to support hard to reach women. So our service users fall into that group, but you have to initiate that conversation. And they will make reasonable adjustments. So they'll fit them in at the end of a clinic when it's a bit quieter, or they'll book double appointments. We find in reality the numbers are tiny. So that's usually quite a good selling point when you're trying to set these things up. And I always think, even if someone's eligible for screening and they don't take you up on the offer when they're an inpatient with you, you've had that conversation. So maybe when someone picks that conversation up with them in the future, they're in a better place to accept screening. There's also, I had a conversation with NHS England. I can send it to somebody to forward on, but I can't remember what it's called, but there's a lot of work now around offering women different positions for them to be in when they're having screening. So the traditional sort of leaning over somebody to do the screening can be quite traumatizing. So what you should be offering now is a different position. So if you were to go to your GP practice, to offer to lie on the side, so I can send you some information about that. And obviously you've got self-screening coming up, haven't you? So I know there's lots of discussions about managing expectations, because obviously if it does show up, then you are going to have to go into full screening. But perhaps how we could offer that in mental health inpatient settings, that there are kits available if someone's willing to self-screen. So that's what we're doing. But there are lots of trusts around the country in mental health that are much further ahead than we are. We're very early stages.
And I think it's interesting because I think there's a lot going on, and it's usually by really like small pockets, if you like, of little things that are going on. There doesn't seem to be like a cohesive national picture. One of the things I have wondered is if this new neighbourhoods initiative takes hold, is this a space where these and other things could potentially be placed, because we can potentially co-locate some of the mental health professionals with the primary care professionals that obviously are needed in this space. And I don't know, the whole thing's very challenging. Suzanne, you had your hand up and then put it down, so I don't know if you just want to join in the conversation. I'm quite happy for us just to have like 10-12 minutes of talking with Beth and Frederique.
I think I've started to forget what I was going to say.
That's my tactic.
I'm at that age where my thoughts come and then they go. I think I was going to say something along the lines of, so I work at secondary care, but we work with community teams supporting people with the SMI annual physical health check. So we're sort of ideally placed if there is that information there. So just say we did have some leaflets, we can then hand a leaflet to sort of target audience. But obviously we only see people once a year. Not everybody agrees to have their health check, but we're always looking for ways we can sort of work towards quality improvement projects within our team. I'm very interested in how we can improve the sort of cancer pathways. At the moment my managers are very much, we have to sort of focus on the interventions we already do, how we can improve those. But for the future, I'd certainly like to get involved in sort of quality improvement projects and things, and in terms of improving that sort of diagnostic rate for cancer in people with SMI.
Yeah, I was really shocked at the how late it is diagnosed. I think we had this discussion, Frederique, and we had a chat. And then the rate of, so it was obviously diagnosed very late, but then the number of people being offered palliative care are less as well. So there's so much to unpack within this area broadly, I think, across all of the cancers.
I think something I see quite often with diagnostic overshadowing is when people are losing weight, and that sort of the weight loss obviously is a red flag cancer symptom, but often in SMI weight loss is also common, and quite often there's a lack of professional curiosity around weight loss, and it's always, not always, sorry, that I'm using the wrong words there, but it's often presumed this must be worsening sort of mental health symptoms. So it's something I sort of quite talk to people about quite often, is about being aware of weight loss.
So Frederique and Beth, if we were to sort of like ask you, I mean, you know, if you've seen any of the previous seminars that I've done, we try and do them like really practically focused, and this I think is hard because it's not embedded. What would you think would be the next like easy steps if someone's coming to watch this webinar because they haven't managed to attend, but they want to do something in their local trust? What would you like to see or think that they could start to do to improve things? Because I think it almost feels like for most places we're starting from a very low point, if that makes sense.
Yeah, I mean, Frederique, you'll have a much better idea than me, but just on that point, Suzanne, because I know you mentioned physical health checks, that's come up in the public involvement as another way of sharing these resources other than the text message reminder. That could be an opportunity. And it also makes me think, I know, because we've mentioned a lot today about having physical leaflets, and I wonder what Frederique thinks about this, is I feel there's a value of having that physical checklist. So I think if you can share the checklist physically, because I was looking at the government guidance, the way they'd adapted it, and that physicality of actually completing a checklist is taken away a bit, and I wonder whether that makes it less impactful. It's less interactive than the original leaflet. I don't know if you have any thoughts about that, Frederique, but yeah, that's my thought, is that a physical copy seems like a good way of going about it.
You forget this population have got memory difficulties.
Yeah, and I think it was seen very much as a conversation starter as well, sort of as much for the nurse as for, it could be the CPN, you know, the mental health nurse, or the OTs, or social workers, as something to start a conversation, and not necessarily just with the intent of leading to a screen, but actually having a conversation about what do you find difficult and what could we do to help. And obviously throughout the PhD, I was thinking I'd love to do something on bowel screening or on other types, because actually I think the checklist could be used for other physical health checks. So I have been thinking about whether we could find funding to adapt it to other conditions or other checks. And we did, obviously, due to lack of funding mainly, but we were thinking about, could it be as an app? Would it be better as an app? But in the end, we did go for a physical leaflet, because even though there were printing costs, and we thought that could be a barrier, actually, I think if someone is having a general discussion with the patient, actually having that on top as a reminder for the nurse, but also for someone to go home with and think about, and maybe discuss it with their partner or whatever, that was felt to be quite useful. So yeah, that was
I
the
know
thinking.
we're nearly finalized our digital booklet. So it's basically a PDF, but the amount of times I've been asked, are you going to print this? Is this going to be printable? For instance, in forensic units, they don't always have reasonable access to digital platforms. And like I said earlier, you've got the memory issues. Sometimes people just need something physical to help them. How do you go back? How do you find the link? You know, all those sorts of things. Not everyone has a smartphone. So you've got things around inequality and access, I think, which are particularly important. But one of the other things that I did think about, and I wondered if this had come up, and this has come up a lot in the research that we've done, and obviously our research is focused on side effects of antipsychotics, but from a primary care perspective, there is a lack of skills, knowledge, and confidence within primary care around SMI and how it manifests. And therefore there's a reluctance, a worry from the healthcare professionals. But actually what I've also had is from the other side of the coin, from service users who've had their physical health checks done in primary care, is they feel like there's a bit of stigma, there's a barrier, if you like, between the healthcare professional and themselves. Did that come up in your work as well? And I guess if that is coming up, that's like a bigger, broader thing that we somehow have to work out how we're going to tackle.
I think there was a huge barrier for them wanting to access primary care, starting from rude receptionists, GP receptionists they felt they were unkind, to feeling misunderstood when they were going for their smear test, or saying, oh, well, you know, we can tell that you've put on a lot of weight, let's get you on the scales, and oh, you know, we can see you might have been self-harming, and how's your, and so all these other things that they did not want to talk about ended up being a barrier for them going for a smear test. And actually the mental health nurses know them quite well, have much better understanding of their, you know, sort of their circumstances, and so they said if we were going to talk to someone, we'd feel much more comfortable talking to the mental health team. So
what's the solution? Is the solution to educate primary care and to do the training there, or is the solution to skill up mental health? I'm just like, because it comes across everything, doesn't it? Every single thing that you get in physical health, it comes back to the same things. Tracy.
This is something that I've tried to look into as part of my development within the physical health role, to see if there is training available. So that
hard, isn't it? It's like
really hard to find anything, so that I can offer it, because we've worked with these ladies 2 years or something, and we've built up the rapport with them, and they'll feel comfortable coming into the clinic for the physical health done every 3 months, that it could be something that if I was trained up, that I could offer within our clinic.
Yeah.
But it's just finding where I could do with the training.
Yeah. Training is really hard, because I tried to explore how we could like develop a training package, either for physical health within mental health or for mental health within primary care. It's really hard to try and find some funding to fund your time to develop it. It's a really difficult thing at the moment. There's no, I don't know what the right word is, no impetus, I suppose, to carry that bit forward. Yet it's a clear barrier to accessing and providing healthcare. And people do need to be trained to provide appropriate healthcare.
Yeah.
Well, we've only got a couple of minutes left. It's been a fascinating conversation. Thank you, guys. I really appreciate that. So if anyone else wants to ask one more thing before we go, speak now, forever hold your peace. And if anyone's got any questions or any suggestions for future webinars, Lauren, what months have we got? I think I'm up to September, I think. But I also think I might have got September and have I got one in the summer free? I've got like a July or a June one free. July is free. So July as a month is currently vacant, and I'm trying to get a series of linked, see if that works, linked webinars around CAMS and antipsychotics in the autumn. But that's proving challenging. That's an understatement, because there are so many people to try and bring them all together to coordinate the diaries. It's a bit of a headache. But what's next month? I can't remember. Oh, it's that Saeed, isn't it, from Kiel?
Yeah.
On switching antipsychotics. And then June is totally forgotten. Oh yeah, the Primrose study. Yeah, okay, that'll be really good. And then so we've got a vacancy for July. If anybody has any suggestions or wants to nominate themselves. We don't always do research. So sometimes what we're really interested in doing is showcasing a small innovation project that has been done in a trust. So if you think you've been doing some good pockets of work, and Sarah, I am looking at you because it sounds like you might have been, and you feel up to sharing that, because I think one of the challenges that I've found in working in this space is, like I said earlier, there is actually some really good pockets of work going on. They're just not published, and therefore we're not learning from each other in the same way. So that's one of the things I was hoping to do through having these seminars, is to share some of this good practice work. So if anyone knows of anything or thinks of anything in the future, or just feels brave, just get in touch. We can, if July feels too soon, we can look later in the year. So thank you very much. I really appreciate the learning that we've obtained, and this will be up in about a week if anyone wasn't able to attend, and look forward to seeing you all next time. Thank you.
Thank you.
Thanks.
Thank you. Bye.